Hi guys, welcome back. So today we're going to talk about heart failure, but I want to go over the diagnosis, which I think I probably briefly mentioned from the last heart failure video, but I just want to go over that again in a bit more detail. Also, mainly want to talk about the treatment of heart failure. How do we go about treating patients with heart failure? So that's kind of what I want to do in this video. For the diagnosis of heart failure, first of all, we ask the patient about the symptoms that they're experiencing. So they might report dyspnea, and we know that that's because of the pulmonary edema that they're experiencing. They might show hemoptysis because, again, the buildup of pressure and fluid in the capillaries within the lungs, that pushes the fluid out into the alveoli, pushes some of the red blood cells out into the alveoli, and then they can cough it up. They can show signs of like peripheral edema, so like pitting edema in the legs and things like that. Also, if it backs up to the systemic circulation, then they can present with organomegaly, so like hepatomegaly, the enlargement of the liver, or splenomegaly, the enlargement of the spleen. So we basically ask patients about their symptoms. They're mainly gonna report like dyspnea, fatigue, and the edema. And after that, we order some laboratory tests. So we can ask for a chest x-ray, for instance. Chest x-ray is helpful, but it's not diagnostic on its own. So if we order a chest x-ray and the results come back, what we should see is cardiomegaly, so the enlargement of the heart. Because it's failing, it's very dilated, it's very weak, it's gonna be enlarged, okay? Also, we're gonna see pulmonary edema in chest x-ray. We're gonna see the fluid buildup in the lungs. Also, we may even see fluid buildup in the like pleural cavity, so we can see like pleural effusion. I think that's it for chest x-ray. Again, this is not diagnostic on its own. And then what we can do is we can also order we can also test for BNP. So BNP is brain natriuretic, I think, peptide. Basically, BNP is a it's like a chemical released by the ventricles. So if the ventricles are really stressed out, in the case of heart failure, they would release BNP. So BNP, again, it's not diagnostic on its own, but it's a very useful measure to help us determine the likelihood of a CHF, a congestive heart failure. And finally, we should get an echo. So an echocardiogram is the gold standard. It's gonna help us definitively diagnose heart failure. So if we order an echo, what we should see is, again, a very enlarged heart. So this is called cardiomegaly. But it can give us more specific things than that. So it can help us determine whether this heart failure is systolic or diastolic. So recall that systolic heart failure is a pumping problem, and diastolic heart failure is a filling problem. So if it's systolic heart failure, what we would see dilated cardiomyopathies. It's gonna show us really dilated ventricles with really thin, weak ventricular walls, okay? If it's a diastolic heart failure, then the echo would show us a very thick ventricular wall, which means that the chamber space is actually reduced, meaning that the heart cannot fill with as much blood as it would normally. So yeah, it can help us determine if it's a systolic or a diastolic problem. On top of that, it can show us if there have been any previous MIs, which can be the reason for the heart failure. Also, it can show us valvular diseases, which can also then lead to heart failure. So before we talk about the treatment for heart failure, I first want to talk to you about one of the most common classification systems that we use. So we have this New York Heart Association like heart failure classification, which provides like an easy way of classifying the extent of heart failure based on the patient's symptoms and their limitations during like physical activity. So it basically groups patients into four like classes. So class 1 is the least severe one. So in class 1, symptoms such as chest pain or like shortness of breath only arise during extreme exertion. Okay, so basically the patients, they don't have any limitations in physical activity. And class 2 is when the patients experience symptoms during like moderate exertion. So the patient has very slight limitations of physical activity. Class 3 is when the patients have symptoms, they show symptoms during mild, even just mild exertion, and they have marked limitations of physical activity. Class 4 is the worst. So class 4, the patients, they show symptoms even at rest. So they have dyspnea, palpitations or chest pain even at rest, and they aren't able to carry out any physical activity without any sort of discomfort. So that's like one of the most common classification systems. I'm telling you this because some of the drugs that we use are more appropriate for the different classes. Sorry guys, I got cold, so I got changed. Anyway, let's carry on. So I've talked about the diagnosis of heart failure. I've briefly spoken about the New York Heart Association functional classification for heart failure. And now, just before we talk about the treatments, I just want to go over really briefly about the compensation mechanism. So the compensation mechanism is basically how someone's heart, like how our hearts respond when our heart is failing. Okay, what does it do to compensate for the heart failure, basically? So recall that heart failure is the inability of our heart to meet the body's demand. So basically, our heart is not pumping enough blood throughout the body to meet its demands. So when it's not pumping out enough blood, it means that our cardiac output is low. Cardiac output is the amount of blood that gets pumped out throughout the systemic circulation in 1 minute. So in heart failure, we have low cardiac output. So when we have low cardiac output, this means that we have a low blood pressure, right? Why? Why does it mean that we have low blood pressure? Recall that blood pressure is cardiac output times total peripheral resistance. So with this equation, it means that if we have low cardiac output, our blood pressure is going to be low as well, because blood pressure is proportional to cardiac output and total peripheral resistance, right? So if we have cardiac output, we have low blood pressure. And what happens when we have low blood pressure? We're not pumping out enough blood. Some of our tissues, they get hypoxic, and that drop in blood pressure can be sensed by our baroreceptors. Our baroreceptors are located in the carotid sinus. Okay, so a drop in cardiac output means a drop in blood pressure. A drop in blood pressure gets detected by the baroreceptors in the carotid sinus. They send this message to the medulla, to the brain, specifically to the cardioaccelerory center of the brain and the motor center in the medulla. And the cardioaccelerory center and it's basically part of the sympathetic nervous system. So when this cardioaccelerory center gets activated, our sympathetic nervous system gets activated. So there are a number of things that happen. First of all, this increases our heart rate. How does it increase our heart rate? It increases our heart rate by increasing the stimulation of the sinoatrial node. The sinoatrial node is the pacemaker of the heart. It's the node that generates that impulse, okay, for the heart, for the whole myocardium to pump, right? So we increase our heart rate by increasing stimulation of the SA node. What else does it do? So it also increases the contractility of the myocardium, right? An increase in contractility means an increase in stroke volume, right? Because stroke volume is affected by 3 factors: afterload, preload, and contractility. If we increase the contractility of the heart, we increase our stroke volume. And if we increase our stroke volume, we increase our cardiac output, because cardiac output is heart rate times stroke volume. So if we increase our stroke volume, we increase our cardiac output. See how the body is reacting because we have a drop in cardiac output. It's trying to elevate, to push that cardiac output back up by doing these things, right? So firstly, we increase the heart rate. Secondly, we increase the contractility of the heart, both as an attempt to increase cardiac output. The third one that happens is we vasoconstrict the arterioles, okay? And by trying, so basically, by trying to constrict those smooth muscles in the arterioles, what does that do? That vasoconstriction obviously makes the lumen smaller, and the smaller diameter, the higher the pressure in those tubes, okay? So this means that we are trying to increase our blood pressure, okay? And remember the connection between blood pressure and cardiac output. If we try to increase our blood pressure, we're gonna increase our cardiac output. Also, in the veins, if you constrict those smooth muscles in the veins, what happens? Veins, they bring back blood to the heart. If you constrict those smooth muscles in the veins, it means that we're trying to push blood back up to the heart even more. So this would increase venous return, which increases preload, which then increases stroke volume, which then increases cardiac output. So this is basically how, you know, the sympathetic nervous system copes with the decrease in blood pressure and in cardiac output. What else happens? So basically, because we vasoconstrict our arterioles, so some of the organs are, especially like, for example, in the renal system, that vasoconstriction means that the kidneys are getting less blood flow. And less blood flow to the kidneys means less glomerular filtration rate. Less glomerular filtration means that we decrease our urine output. If we decrease our urine output, it means we retain more water. If we retain more water, we increase our blood volume, and an increase in blood volume means that we increase our blood pressure, which then means that we increase our cardiac output, okay? Also, another thing that happens in the kidneys, we activate our renin, angiotensin, aldosterone system, right? So in the kidneys, we have juxtaglomerular cells, or JG cells, and these cells, they get activated because of that decrease in perfusion in the kidneys, right? They also get activated by the epinephrine release and, you know, by the sympathetic nervous system, but they respond because we decrease the perfusion to the kidneys. So when the JG cells get activated, they release something called renin, and renin is an enzyme that converts angiotensinogen made by the liver to angiotensin I. Okay, so renin converts angiotensinogen made by the liver to angiotensin I. Angiotensin I then travels up to the lungs, and it gets converted into angiotensin II by a specific enzyme called ACE, angiotensin converting enzyme. Again, this is found in the lungs. What is the point of all of this? What is the purpose of angiotensin II? So angiotensin II has multiple different functions or roles. So basically, angiotensin II, what angiotensin II does, firstly, is it stimulates the posterior pituitary gland, right? The posterior pituitary gland releases ADH, antidiuretic hormone, and that hormone travels all the way back to the nephron. And as it says in the name, antidiuretic, it prevents diuresis by trying to increase water reabsorption, okay? So angiotensin II stimulates the posterior pituitary to release ADH. ADH travels to the nephron and increases water reabsorption. So if we increase our water reabsorption, we increase the blood volume. We increase the volume of blood retained, the volume of fluid retained in the body, right? This increases our blood volume, which then increases our blood pressure, which then increases our cardiac output. Okay. The second thing that it does is it basically it travels to the adrenal gland, especially the zona glomerulosa of the adrenal glands. And in this zona glomerulosa, another hormone gets released called aldosterone. Aldosterone, similarly to ADH, travels back up to the nephron, and it also promotes the reabsorption of water, and not just that, but also the reabsorption of salt, right? So remember that where salt goes, water follows. So if you increase the reabsorption of salt and increase the reabsorption of water, less water would be peed out. So this is going to decrease our urine output, meaning that more fluid will be retained in the body as an attempt to increase blood pressure and increase cardiac output. And finally, what angiotensin II can do is it can cause vasoconstriction of the arterioles. And if we vasoconstrict our arterioles, we raise our total peripheral resistance. And based on the equation, blood pressure equals cardiac output times total peripheral resistance. If we increase our total peripheral resistance, we increase our blood pressure and we increase our cardiac output. So the activation of the sympathetic nervous system and the activation of our renin, angiotensin II, aldosterone system are the compensation mechanisms that the heart and the body tries to do to help us with this failing heart. So as you can see, they actually increase cardiac output, yes, and they increase blood pressure, yeah. So it's doing what it's supposed to do, but this can only work for a certain time, because over time it's gonna backfire. It's actually gonna make heart failure worse, and I'll explain why. So at the beginning, you know, all of this trying to increase cardiac output by increasing heart rate, increasing contractility, increasing vasoconstriction is all good, because again, we're achieving the desired result, which is to increase our blood pressure and increase our cardiac output to help the heart, you know, pump blood throughout the whole body, to increase perfusion in tissues. Let's think about this for a sec. What was the first thing that we did? So the first thing that we did is we increased our heart rate by the increase in the stimulation of the sinoatrial node. So if we increase our heart rate, it means that our heart is beating a lot faster than normal, right? At the beginning, it's fine, it's good, because an increase in heart rate increases our cardiac output, remember? Because cardiac output is stroke volume times heart rate. So by increasing the heart rate, we try to increase our cardiac output. But over time, because we're making the heart beat so fast, it's not getting to spend enough time during the diastole. And during the diastole is when the heart gets its own blood supply. So imagine this for a sec. We have a failing heart. We try and make it beat faster, so we increase cardiac output, fine. But because we've increased heart rate, we've shortened the time that it gets to get its own blood supply. So it's gonna fail even more, because the myocardium isn't getting enough blood supply, right? So that's the first thing. What was the second thing that we did? The second thing that we did is we increased the contractility of the heart. So when we increase the contractility of the heart, what did I say that affects? That affects stroke volume. An increase in contractility means an increase in stroke volume, right? And if we increase our stroke volume, we increase our cardiac output. It's all fine and good at the beginning, because that was the point. We're trying to help the heart by increasing cardiac output to perfuse all the tissues, right? But an increase in contractility also means a greater oxygen demand, because they're working even harder. The myocardial cells are working super overtime at this point, because we're trying to make them work even harder than what they were used to, because we increase the contractility, we increase the force of contraction. That requires more oxygen. But they're already failing, you know, they're already not getting enough oxygen because we've increased the heart rate, and now they're getting even less. So basically, the demand for oxygen has gone up because we've increased contractility, but the supply has gone down because we've increased the heart rate, and it's not getting enough time to spend in diastole where it gets its own blood supply. So what's going to happen then? then some of those cells are definitely not going to get enough oxygen. Okay, so we've made the situation even worse. What was the third thing that we did? The third thing that we did is we tried to vasoconstrict the arterioles in the venous system. So we vasoconstricted the arterioles because that increases total peripheral resistance, and an increase in total peripheral resistance means an increase in blood pressure, right? Because blood pressure is cardiac output times total peripheral resistance. So therefore, increasing total peripheral resistance increases blood pressure, which then increases cardiac output. Again, all fine and good at the very beginning. It's gonna help, but it has its limitations because, right, when we increase total peripheral resistance, what does this mean for the heart? It means that now we have such a high pressure that the left ventricle needs to overcome to pump blood throughout the systemic circulation. Because we have increased the total peripheral resistance, it's gonna make it harder, even harder, for the left ventricle to push blood out to the systemic circulation because it has to overcome a much higher pressure. So our failing heart, which is already so weak, and now you're asking it to work even harder to push blood out to the systemic circulation, it's just not gonna do it because it's already weak, you know, it can't. So again, we've made the situation worse. And what was the last thing that we did? We vasoconstricted the venous system. So the venous system, the veins take blood back to the heart, right? So if we vasoconstrict the venous system, we increase our preload. We increase the amount of blood going back to the heart, yeah? And an increase in preload increases stroke volume, which increases cardiac output. Again, all fine and good at the beginning. But then, what have we done now? We've made it worse again, because if we vasoconstrict those veins, we increase preload, like I said. But in a failing heart, increasing preload means increased stress in the heart. Imagine a heart and we just dumped a lot more fluid in it when it's already very dilated, very weak. It's barely, you know, it just can't deal with that fluid overload, and we're just shoving in more and more and more and more fluid inside it when it's already very weak, you know. So it's not gonna push all of those extra fluid out. So it's just gonna be dilated. It's gonna be very overwhelmed. So again, these compensation mechanisms, they work at the beginning because they increase your blood pressure and cardiac output. But over time, they can actually make heart failure worse. And finally, we can talk about the treatments. So recall that according to the New York Heart Association, we can group heart failure into 4 different classes based on the extent of the disease and if there are any limitations in their physical activity. So the drugs that we commonly use for class 1 are the first-line treatments for heart failure. So this includes ACE inhibitors, Arbs or angiotensin receptor blockers, beta blockers, as well as diuretics. So those 4 are the first-line treatment. So ACE inhibitors, Arbs, beta blockers, and diuretics. So starting with ACE inhibitors, as the name suggests, they inhibit the ACE enzyme. So the ACE enzyme is found in the lungs. It converts angiotensin I to angiotensin II. So if we inhibit the action of this enzyme, we get less angiotensin II circulating around the bloodstream because we're going to convert less angiotensin I to angiotensin II, therefore reducing the amount of angiotensin II circulating in the body, right? So if we decrease the amount of angiotensin II, what do we decrease? So remember that angiotensin II vasoconstricted our vessels. So we then get less vasoconstriction. If we get less vasoconstriction, we're not upping the total peripheral resistance, right? So basically, we're reducing afterload. We're making it easier for the left ventricle to pump blood throughout the body. Because we're not vasoconstricting, we're basically not pushing up the pressure that the left ventricle needs to overcome. Therefore, it's going to be easier for it to pump blood throughout the body. Less stress in the heart because the left ventricle isn't working as hard, right? So that's the first thing. The second thing is that we produce less ADH. Remember that angiotensin II goes to the posterior pituitary gland, stimulating it to release ADH, which increases water reabsorption, right? So if we inhibit the production of angiotensin II, we basically inhibit the release of ADH. If we inhibit the release of ADH, more urine would be peed out, okay? Because we're not reabsorbing as much water. And this means that there's less total circulating volume, which means less preload. And less preload means like less stretch in the heart, less pressure in the heart, less stress, because we're not just dumping in a lot of fluid in our weak, failing heart, okay? So I hope that makes sense. And then this third thing that we inhibit is we inhibit the release of another hormone called aldosterone. Aldosterone is released from the zona glomerulosa of our adrenal glands. And again, this is because of angiotensin II. If we don't have many angiotensin II circulating around, we're not gonna stimulate the release of aldosterone. And aldosterone promotes the reabsorption of water and salt, okay? So if we don't have a lot of angiotensin II circulating around, we don't have a lot of aldosterone, we're not gonna reabsorb a lot of salt and water. That means our urine output is gonna be higher, and the total blood volume, total fluid volume is gonna be low, meaning less preload, again, less stress for our heart. So that's how that's how ACE inhibitors work. And I don't know if I've mentioned, but examples of this include lisinopril, captopril, enalapril, anything that ends with pril, okay? That's an ACE inhibitor, right? So the most common, the thing is, there are some symptoms that may not be tolerable for some patients. So if the patients experience like a dry cough and angioedema, which are very common side effects, and the patients can't tolerate these side effects, then we can use Arbs instead of ACE inhibitors. So Arbs are angiotensin receptor blockers. Angiotensin receptor blockers, again, as the name suggests, they block the receptors for angiotensin II. So if you block the receptors for angiotensin II, basically angiotensin cannot bind to them and cannot elicit its effects. So it basically does the same as ACE, but the mechanism of action is slightly different. So instead of inhibiting the ACE enzyme, it blocks the receptors for angiotensin II, producing essentially the same effects. We get less vasoconstriction, which means we decrease our total peripheral resistance, we decrease our afterload, making it easier for the left ventricle to pump blood throughout the body. We decrease the production of aldosterone and ADH, which means that our urine output will be higher, we don't have a lot of volume in the body, less preload, less stress on the heart. So they work essentially the same way. Examples include losartan, valsartan, and candesartan. The third drug that we use for class 1 heart failure is beta blockers. So beta blockers, very, very important to remember, they are contraindicated for decompensated heart failure. So never, ever, ever prescribe beta blockers to patients with decompensated heart failure. Contraindicated, okay? So beta blockers. There's two different types. So there's some beta blockers that are more cardio specific, so they just act on beta receptors, and there are others like carvedilol that has like a mixed action, so they act on beta blockers and on beta receptors and alpha receptors as well. So the more cardio specific ones, an example would be metoprolol, for instance. It's more cardio specific because, as I said, it only acts on beta receptors, which are found in the heart. So essentially, beta blockers, let's take the more cardio specific ones as an example, what they do is they are negative chronotrops, so they reduce heart rate, and they are negative inotrops, which means that they reduce the contractility of the heart. Also, because okay, the renin, angiotensin, aldosterone system, that's also stimulated via that. They also have beta receptors. The JG cells have beta receptors. So in a sense, beta blockers also inhibit the renin, angiotensin, aldosterone system, meaning that we don't produce as much aldosterone, meaning that we don't reabsorb as much salt and water. So we pee out a lot more. Our circulating blood volume becomes less preload, less stress on the heart. So that's how they work. The beta blockers with mixed action, so the ones that act on beta receptors and alpha receptors, they do the same. Plus, alpha receptors are found in like the vasculature, so they also relaxes the vessels. So they do the opposite of vasoconstriction, meaning that we decrease our total peripheral resistance, helping our left ventricle pump blood much easier around the body. So that's how beta blockers work. The fourth one are diuretics. So diuretics are used when ACE inhibitors, Arbs, or beta blockers didn't work, but also when we have fluid overload. So if the patient has signs of edema, right? So diuretics, I hate to talk about pharmacology, but as medical students, we need to know this. Okay, so for diuretics, we have so many different types. So we have, I'll mention two that we commonly use. So we have loop diuretics and thiazide diuretics. So loop diuretics, an example is like furosemide. So loop diuretics, they basically they act on the sodium potassium 2 chloride transporter, which means that they don't allow sodium, potassium, and chloride to escape out of the nephron. So they basically keep sodium, potassium, and chloride inside the nephron. And you know, with this ions, they carry water with them. So if they stay inside the tubule, inside the nephron, then they carry water with them, and we pee out that water. So basically, we don't reabsorb as much water. Okay, so that's how they work. That's very, very basic, but you get the principle. And if we don't reabsorb as much water, then that means that we decrease preload and decrease the stress in the heart. Okay, thiazide diuretics like hydrochlorothiazide and metolazone. I think metolazone. I think it's metolazone, which is a thiazide-like diuretic. Anyway, thiazides, they work they work on the sodium chloride transporter in the distal convoluted tubule. And again, what they do is basically they don't let salt come out, so they just stay there with water, and then we pee out water and salt. So the total circulating volume becomes less. We don't keep as much fluid in, and we pee a lot more out, so that decreases the preload, again decreases the stress in the heart. So that's how diuretics work. Moving on to heart failure drugs or treatment that we use for class 3. So if it's gotten to class 3, which means that even at mild exertion the patient experiences symptoms, we give other drugs. So we can give what do we give? So we give aldosterone inhibitors or aldosterone antagonists, neprolizin inhibitors, hydralazine, and isosorbide dinitrate. So starting with aldosterone antagonists. So examples include like spironolactone and eplerenone. So basically, as the name says, it antagonizes the actions of aldosterone. So if we antagonize the action of aldosterone, then we're not gonna reabsorb a lot of salt and water, which means that we decrease preload, we decrease the stress in the heart. So that's essentially how they work. Also, the other good thing about spironolactone, for example, about aldosterone antagonists, is that they are potassium sparing, and also they are used if the patient has like history of MI, because they reduce the chances, they reduce the remodeling of the heart. The next class 3 heart failure drug that we can use is neprilysin inhibitors. So usually these neprilysin inhibitors are used with in conjunction with like Arbs. So most specifically valsartan, I think. So neprilysin inhibitors like sacubitril are used with Arbs, most specifically valsartan, because valsartan can enhance the effect of this drug. So what exactly do they do? So neprilysin, recall that I told you in the beginning that when the ventricle is really stressed, it releases BNP, right? So BNP is basically like a chemical released by the ventricles of the heart when they're really stressed, in the case of heart failure, for instance. And BNP actually antagonizes the effect of angiotensin II. So BNP is good because it just antagonizes the effects of angiotensin II, which exacerbates heart failure in the long run, you know. But the problem is this BNP gets it gets degraded by an enzyme called neprilysin. So we give neprilysin inhibitors to inhibit that enzyme, so that we keep BNP circulating around to antagonize the action of to block the action of angiotensin II. So that's what we use it for. And like I said at the beginning, the effects can be enhanced by the use of an Arb like valsartan. So again, if we reduce the actions of angiotensin II, then it means we reduce the vasoconstriction, decreasing total peripheral resistance. We reduce the production of ADH and the production of aldosterone, which increases salt and water absorption, increasing preload, increasing that stress in the heart. So it antagonizes, it prevents all of that from happening. The third class 3 drug is hydralazine. So hydralazine is actually safe in pregnancy. So in pregnancy, it can even be the first line treatment. So hydralazine is used when Arbs and ACE inhibitors have failed to work, and again in pregnancy. So what they do is that they vasodilate the arterioles. So they promote vasodilation of the arterioles by increasing the nitric oxide, right? Nitric oxide is a vasodilator. So if we vasodilate our arterioles, then that means we reduce the total peripheral resistance, which then reduces the afterload, which means that it's going to be easier for the left ventricle to pump against that pressure, because it's going to be a much lower pressure. Okay, so that's how hydralazine works. And isosorbide dinitrate has a similar mechanism of action, but instead of vasodilating the arterioles, they work on the venules. So they vasodilate the venules. So similar mechanism of action, it vasodilates the venules by increasing nitric oxide, which is a vasodilator. So if we reduce the if we vasodilate our venules, what's that do? It decreases our preload. When we decrease our preload, we decrease our stroke volume, and we decrease like the stress in the heart, because our heart is already dilated, it's already failing. So if we lessen the amount of fluid overload, the amount of blood we're just dumping into it, it's gonna make it less stressed. Okay, it's gonna reduce the stress on the heart. So that's how isosorbide dinitrate works. And moving on to the drugs we use for class 4 heart failure. So these are like the last line of therapy. This means that the patient is in a really severe heart failure. So we use digoxin. So digoxin is it's a positive inotrope, so it actually increases the contractility of the heart, but it's a negative chronotrope, which means that it reduces heart rate, and it does this by slowing down the conduction through the AV node. Okay, the next one is dobutamine. So dobutamine is used for decompensated heart failure and for patients with really low cardiac output and blood pressure. So patients who are super close to getting a cardiogenic shock. And in terms of decompensated heart failure, I want to quickly talk about the treatment. So we use dobutamine and we use LMNOP, right? So dobutamine, LMNOP. So L is for Lasix or furosemide. So that's just to decrease the fluid overload, decrease the edema, whether that's pulmonary or peripheral, okay? N is for nitrate. So we can give hydralazine or isosorbide dinitrate to vasodilate their vessels, their venules, and their arterioles. I miss M. So L is for Lasix furosemide. M is for morphine. Morphine for the pain that they're experiencing. N is for nitrates like hydralazine and isosorbide dinitrate for vasodilation. O is for oxygen. So we need to give them high flow oxygen, whether that's via CPAP or a BiPAP, or just high flow oxygen via nasal cannula. LMNOP. P is for position. So we have to be mindful about their position because they would get orthopnea. So that's shortness of breath when they're like supine. So we need to make sure they're always on an incline to help them be able to breathe, So that's the protocol. Those are like the treatments we give for decompensated heart failure. So the dobutamine and then LMNOP, Lasix or furosemide, morphine, nitrates, hydralazine, isosorbide dinitrate, oxygen, and position.